ahead and introduce our speaker today. Joe Alcock's the speaker. He's a practicing emergency physician and a professor at the University of New Mexico. He's in the Department of Emergency Medicine. I'm really excited to have Joe here today. I've known Joe for a while, especially through the society, ISEMP, International Society for Evolutionary Medicine and Public Health, and it's always great fun to talk with Joe. His current research uses evolutionary approaches to understand cooperation and conflict in the human gut microbiome, and he's very interested in relating this to acute and chronic diseases of a wide variety. And Joe was one of the first people to be nominated as a speaker in Club EvMed, and so we're really glad that we've been able to line things up and have him participate. He's both teaching and practicing. He has clinical time as well, and so it's always a little challenging to figure out how to line things up like that. But anyhow, Joe, it's great to have you, and I'll turn things over to you.
Thank you, Charlie. Thank you, Meredith. Well, this is great fun. I'm really excited to be with you virtually and to talk about this topic. So yes, I think what I'll do now is I'll bring up a PowerPoint, and we'll see if we can give that a go. And all right, so we're going to talk about cytokine storms, and I found this image on Google yesterday, just putting that term into the search box, and it brought up this article on BBC. And really, cytokine storms are kind of all over the place when it comes to the media and scientific discussion about COVID. And you can see they have an ominous cloud there, and the title here is When the Body Attacks Itself. And then the subtext is when our immune systems mobilize, they can sometimes go into overdrive, triggering a destructive overreaction called a cytokine storm. Why does it happen, and how can we stop it? So we'll talk about that, but we're also we're going to talk about some evolutionary questions that I think arise when it comes to cytokine storms. So first off is, why would the immune response overshoot and cause more harm than good? And Randy Nesse and others have written about this, Ed LeGrand, who's on this call also, and I have come up with some hypotheses for why this might happen sometimes, and so we'll talk about that. But secondly, I think we should ask ourselves, should this be a common thing? Should we expect this to happen all the time in our patients with COVID or patients with sepsis or other kinds of conditions? And then we'll finally get to what is an area of interest of mine, which is, why is the immune system so resistant to medical intervention? Because we haven't had too much success coming up with ways to intervene during infections. And then finally, can we use EvMed to inform treatment decisions for individual patients or populations? So that's the goal. So back to our cytokine storm. Here is kind of an encapsulation of it. So this author who wrote a paper on vitamin D and COVID, he wrote, what seems to kill a majority of COVID-19 patients is not the destruction of the lungs by the virus, it's complications from the misdirected fire from the immune system. So again, what kills us in this viewpoint is our immune system, not the virus. And this has been echoed by leaders in the field. Peter Piot was written up in Science. He's one of the guys who did the original work on Ebola virus. And he wrote of his own COVID-19 infection, that it's a result of your immune system going into overdrive. And again, he says many people don't die from the tissue damage caused by the virus, but the exaggerated response of the immune system. And of course, this has treatment implications, right? If you think that the immune system is the problem and it's killing you, then it follows that one should be treated with some kind of immunotherapy. So he writes, I'm still under treatment for that with high doses of corticosteroids that slow down the immune system. So I think the point here is that a cytokine storm is really it's not just a fact, or I'm saying it's not a fact, it's a hypothesis. And the hypothesis is that the immune system is the problem, and so the solution, therefore, should be something like corticosteroids. So with regard to cytokines in COVID-19, here's a table that lists a variety of these immune regulatory molecules. These are signaling molecules that mammals and other organisms use. And so you see things like IL-6, which has had lots of attention as a pro-inflammatory cytokine. Also TNF-alpha, which is really thought to be one of the most strongly pro-inflammatory cytokines in the body. But of course, there are many. And with regard to treatments, here's a list, and this was a truncated list. It's actually on 2 pages of therapies directed against cytokines and directed against different sorts of these inflammatory pathways. Most of them are monoclonal antibodies that are directed against either TNF alpha or some of the other cytokines like IL-6. But of course, it also includes corticosteroids and IVIG and a variety of other things too. So cytokine storms have treatment implications. To me, though, this is kind of like Groundhog Day because cytokine storms did not arise with COVID-19. The idea has been around really since the early 1990s. It was first thought of with graft versus host disease in patients getting immunosuppression for organ transplant, but then it rapidly transitioned into thinking about sepsis and septic shock, which of course is an overwhelming infection and a bloodstream infection that sends people to the hospital and kills a lot of folks. So people have tried to treat cytokine storms in sepsis for a very long time. So here's a paper from 1991 that looked at cytokines during sepsis, and they write that, again, the logic behind this is that cytokines are elevated in these severely ill people. So we find that IL-6 is super high in patients who are very sick with sepsis. So it stands to reason, especially if we believe that the cytokines are the problem, that we should be able to reduce those cytokines and improve mortality. So this is a 30-year-old idea, at least. It really actually dates to the late 1980s. So how did this all work out? Well, people did come up with varieties of monoclonal antibodies and immunotherapies. This is one that was directed against tumor necrosis factor, the Fc fusion protein of tumor necrosis factor, published in the New England Journal in 1996. And you can kind of see the result at the bottom there. So in the text, they write, the increased mortality rate among patients treated with this agent as compared to placebo was unexpected. So actually,
Everyone, we'll work on getting Joe's audio back. Looks like he may have been disconnected. We'll be back online in just 1 second. Give us a moment.
In the meantime, feel free to use the chat box to raise any questions, start to populate that with questions or comments.
are we all back?
Hey.
Yes, you're back.
That's good. I hope I didn't hit something. I may have. Okay, let's get back to the PowerPoint. I think I'm going to bring back my share screen. All right, guys. Hopefully we didn't lose anybody. So the point I was going to make here is that even though these agents have not worked in sepsis, they were FDA approved for autoimmune diseases. So many of these things that were first federally funded in NIH trials for sepsis found their way into treatment for Crohn's disease, rheumatoid arthritis. And so some of the things you may have heard of, Enbrel, Remicade, Humira, there are other drugs that fall into this category. So again, these medicines didn't work for infection. They do seem to work for autoimmune diseases. And yet we've had articles like this in the Lancet saying we need to use these same treatments, the very same ones that didn't work in sepsis we should use for COVID-19. And so the question is, do we think that's going to work? I think the lesson that we've gotten from the sepsis trials, which of course is the setting of infection, is one that should give us caution here. And so John Marshall back in 2014 wrote that over 100 randomized trials have been done, and none of them, with one short-lived exception, and that was a medicine called Xigris, ever resulted in a treatment. Xigris was taken off the market 10 years later after its approval because it didn't work. And this paper published at the same time as that Marshall paper showed every one of these little gray boxes that has a terminus is one where that treatment strategy didn't work. but you can see there are 4 arrows there. So in 2014, there were 4 treatment strategies that were still under consideration for using an immunomodulatory treatment for sepsis and infection. And they were statins, thrombomodulin, anti-LPS, polymyxin column, and corticosteroids. How did this all work out? The statins struck out. We learned this in 2014. The biggest trial for statins didn't work. The thrombomodulin trial, as we can see here, did not reduce mortality. So that one didn't work. The biggest trial ever done for steroids, corticosteroids in sepsis, was this adrenal trial published last year in the New England Journal. And as you can see, it didn't affect survival at all. And the last one is this polymyxin B hemoperfusion. So here they're taking blood out of patients who are very sick with infection. They're running it through a little column. They're absorbing lipopolysaccharide, which is the gram-negative cell wall building block, to try to reduce the endotoxin levels. This didn't work. It did not reduce mortality at 28 days. That was published in 2018. So all 4 of these approaches has not led to a successful therapy to date. And that is not despite lack of trying. There have been, I count close to 200 trials that have been done that use this approach of trying to reduce activation in patients who are very sick with infection. So John Marshall, the guy that wrote that 2014 paper, he wrote this in JAMA that really takes something of an evolutionary approach. He says that the way that we recognize endotoxin and our response is evolutionarily conserved. And of course, it's complicated. And he says that, he argues that this detection of endotoxin and the responses that happen may have an adaptive and beneficial role in patients with infection. I tend to agree with this. And this really gets us into the smoke detector idea. The fact that we have toll-like receptors that recognize endotoxin and mediate a response is our way of detecting threats that are in our bodies. So Randy Nesse has written in the New York Academy of Sciences, and then later about this idea of the smoke detector principle, that we should have threat detectors, both behavioral when it comes to things like panic, as well as immunological. And I mentioned our ability to detect lipopolysaccharide or endotoxin as an example of an evolved signaling response that typically directs an adaptive way of coping with that threat. But the way, if you're gonna have a sensitive system of detecting threat, then occasionally we should expect overshoot. And so, as we see here, we want a smoke detector that goes off every single time that there's a blaze of any kind. And to get this reliability, we're willing to accept false alarms. And of course, the same is true when it comes to endotoxin. But that doesn't mean that the overall scheme is maladaptive. It may be perfectly evolved. We just simply get the occasional overshoot. So this image here is a picture of a patient with secondary syphilis. And the phenomenon that they're describing in this paper is something called the Jarisch-Herxheimer reaction. And this is an example, I think, of overshoot. So patients with syphilis, the organism, the spirochete, has a way of masking its outer surface protein so it is undetected by the immune system. But when an antimicrobial is given, originally it was mercury compounds, and now of course it's penicillin, that changes the outer membrane protein so that changes their conformation and allows the immune system to recognize the infection. So when that happens, all of a sudden blood pressure drops, a high fever spikes, patients get a worsening rash, and they get quite sick. I think this is a good example of an immune overreaction. It occasionally kills people, although very rarely. And it can possibly be treated either by giving the antimicrobial differently or by giving steroids. So overshoot does happen, and this is an example of it. The other hypothesis, besides the smoke detector principle, that Ed LeGrand and I wrote about in 2012 is this idea of immune brinksmanship. And this is the idea, or the recognition, that our immune host defenses, especially the acute phase response and fever, come with a cost and actually can involve some tissue damage to the host. But this is a gamble that our bodies are willing to take because the idea is that most of the cost and the inability to cope with the cost is directed at the pathogen. So again, this is an immune gamble. The analogy is something like trade sanctions in between countries, like what the US has with Iran. The idea that by decreasing trade, we're harming ourselves, but we hope, not me personally, but our government hopes to harm Iran more than we harm ourselves. The other analogy here is cancer chemotherapy. And just like a casino, the odds are in our favor when this happens. In other words, the dice are loaded to favor us when we engage in these gambles. And most of the time, this has paid off for our ancestors that are confronted by infectious threats. But it doesn't mean it always pays off. And sometimes individual patients can get sick. So we see that with this Kawasaki-like disease in children that get coronavirus. This is another example of an overreaction, I think, that can be treated, we think, probably with steroids and IVIG. So occasionally we lose that immune gamble and we end up with bad outcomes. So here is how I conceptualize this. We can have overshoot. We should expect that overshoot should happen. And really, the examples that come up for this most of the time have to do with mismatch. So with that Jarisch-Herxheimer reaction, the novel condition is antibiotics. Of course, we have autoimmune diseases that are related to excessive hygiene, which I haven't talked about. And we might argue that, say, with coronavirus, if we want to come up with a rationale for why this might be excessive in general, it's possible that we haven't had sufficient time to deal with a brand new pathogen that has switched hosts from bats to pangolins and then to us. Another thing to consider is that there are trade-offs involving multiple pathogens. So many COVID patients also have other respiratory infections at the same time. Of course, we are dealing with a chronic kind of low-grade infection, if that's one way to look at it, when we look at the microbiome. And if we get very But I'm going to argue that in general, when we're treating cytokine storms, we shouldn't expect it shouldn't be common. And that is because when we deal with these fitness costs of infections, part of it is caused by the pathogen harming us. But as we've talked about with brinksmanship, there are also costs of immunity and trade-offs, resource allocation trade-offs. And when it comes to the host's ability to reduce these fitness costs, it's much easier to reduce the cost of immunity than it is to attack a pathogen. So I look at this as sort of being the low-hanging fruit in terms of an evolutionary solution to a problem. So that leads me to my final point here, which is, why is our immune system resistant to improvement? And I think it's because natural selection should be expected to reduce fitness costs imposed by excessive immune responses and should be constantly paring those down to the minimum. And the other issue is that when we doctors try to intervene by using some of these immunotherapies, this is not our immune system's first rodeo. Pathogens have been improving their own fitness by disabling or circumventing immune responses for a long time, probably since the first multicellular organism. So that has given us an immune system which has complex regulation and redundancy. So we shouldn't be surprised by the fact that our efforts to disable those mechanisms have a very low probability of success. I think that's all I have in terms of this. But I want to leave you with this idea that cytokine storm is a hypothesis. It comes with testable predictions. Those predictions are that interventions that reduce cytokinemia should reduce morbidity and mortality. So we have people proposing anti-TNF alpha, anti-IL-6, people recommending vitamins to tamp down oxidative stress in the immune response, and even crazy ideas like giving whole body irradiation, low dose of, cancer doses of radiation to try to reduce immune responses. I predict these are very unlikely to succeed for the reasons that I've kind of gone over. So at this point, I'm gonna open it up to discussion.
Great, thank you for that great overview. It looks like we do have a raised hand already, so we'll go straight to that. Looks like Riyad Abed, you are unmuted. Feel free to ask your question. Nope. Okay, now, oh, sorry, we keep unmuting at the same time, I think. Riyad, are you there?
Aren't I?
There, you're unmuted now. Please ask your question.
Great.
Sorry.
Thank you very much. Yes, thank you very much, Joe. Yes, I'm Riyad Abid, psychiatrist from the UK. I was thinking about the variations that we have in the fatality of COVID-19, across the world. And one particular observation is that the fatality in low and middle income countries seem to be, with some exceptions, Iran being one, but otherwise low and middle income countries seem to have had a much lower fatality rate than the high income countries, Europe, US, and so forth. And I don't believe that this is just simply an artifact of data collection, because I'm in contact with colleagues in the Middle East, Iraq, where I have constant discussions and so forth. You can't hide deaths. You can hide cases, but you can't hide deaths. So I wonder what your thoughts are with regard to the question of mismatch and the cytokine storm being less of a problem in the low and middle income countries compared to high countries, and what kind of mismatch is going on? Is it a hygiene mismatch, or is it something else?
That's a great question. Of course, we don't really know the answer. And to your first point, that with regard to data collection, we'll probably have a better picture of this in a year or two once we get really an idea about the case fatality rate in different places. But it's very plausible that it should be different in different places for both infectious burden reasons, possibly human genetic variation reasons, but even more likely nutritional reasons. There could be a bunch of reasons why we should expect differences between different places. I think that maybe middle and lower income countries, because they typically have a higher burden of infectious disease generally, they may be coming into this pandemic with a different average kind of immune experience and immune state. That may account for some of the difference. But really, we just don't know.
Thanks.
Great question, though.
Great. Well, there's a lot of great questions in the chat box. I'll go to one from Sonia Cavagelli. Sonia asks, instead of dampening the cytokines, is it more possible to dampen the dangerous downstream effects such as fever, immune cell toxicity, etc.?
So I think that, the challenge, or there are multiple different ways that we can go after COVID infections. So one is, I think, tamping down immune responses generally. And we can do that by attacking cytokine storms or by using anti-fever kinds of therapies. I put those all into the same bucket. Of course, the regulatory mechanisms that are responsible for those are complicated, but they're all kind of the same idea, that the host damage from the immune response or fever is excessive. But the other way to go after COVID is to attack viral replication or some aspect of the virus itself. And so that's what Remdesivir is supposed to do, although that medication probably doesn't work very well. And I think that given the choice between attacking our own immune system or attacking the virus, that our efforts should be mostly directed towards attacking the virus. And with regard to fever, I highlighted for my class and on the blog recently, I have a blog called evolutionmedicine.com, this idea that the Surviving Sepsis campaign recently recommended that we treat fever in COVID. And it really falls into this bucket of thinking that fever is harmful. Of course, this is a very old evolutionary idea. It dates back to Matthew Kluger in 1976 in Science, who showed that behavioral fever in lizards improves survival. And I feel quite strongly, I know that Ed LeGrand, who's also on this call, agrees that not treating fever is the way to go when it comes to COVID-19. That's a whole different topic.
Great. So just a reminder, you can raise your hand to ask questions. We'll go back to the chat box for now. So Eric Shattuck had asked earlier in the presentation whether the sepsis trials were viral, bacterial, or a mix, and whether pathogen reproduction or transmission strategy might affect immunomodulatory treatments.
So great questions. To the first point, many of them simply looked at the syndrome of sepsis. So patients who came in and were admitted to intensive care with some evidence of some evidence of infection like fever, but also low blood pressure, elevated heart rate or respiratory rate, elevated white blood cell count. So probably the majority of these patients had a bacterial infection, although that's not certain. Some of them presumably also had a viral infection, but you were right, I think, Eric, to suggest that That isn't necessarily a perfect analogy for what's going on with a severe viral illness and viral pneumonia. I can tell you that we've tried immunomodulatory treatments for severe influenza, both H1N1 and the avian influenza epidemic of a decade ago. And there is not any kind of conclusive evidence that immunomodulatory treatments help for viral acute respiratory distress syndrome or a sepsis-like syndrome caused by viruses either. Let's see, there was a second part of that question. Pathogen reproduction transmission strategy? Maybe. I guess I don't have an answer to that second part.
All right, open question. Looks like we have a raised hand, so we'll go to Paul Goldsmith. Paul, you're unmuted now. Go ahead.
Oh, well, thank you. And first of all, I just want to thank you for organising this and opening it up to people who, like myself, who wouldn't normally get to participate in such an interesting discussion. I'm very, very grateful for that. I'm a neurologist from the UK, and a couple of observations and a question. There are a lot of brain infections. We would normally give steroids up front with treatment, whether that's standard meningitis, particularly with TB, but also viral, such as varicella. And more broadly, this immune state is sort of very well recognised in AIDS treatment with IRIS, immune reconstitution syndrome, where you go from having very low CD4 counts and then you replete the CD4 producing cells and get an aggressive immune reaction. And more recently, this has been very commonly recognized in multiple sclerosis treatment because the inflammatory drugs have become so effective at dampening down all of the inflammation, and then they're stopped. For example, if someone becomes pregnant or has to stop the drugs for another reason, you get a really aggressive inflammatory reaction. So I was sort of wondering with COVID, what does the CD4 count profile look like? Because the nasty reactions seem to be quite late on in the conditions that people do okay, and then it's sort of day 7, 8, 9. Are you seeing some sort of recovery and then things go overboard at that stage?
So there's a lot to unpack. Thank you very much for that, that really good question. I think that the immune reconstitution inflammatory syndrome that you mentioned, both with HIV patients that get antiretroviral treatment, but also that we see with patients receiving some of these rheumatological medications who then get tuberculosis. That's an example, I think, very much like that Jerish-Herxheimer reaction, which is a legitimate example of overshoot that might sometimes benefit from a short course of corticosteroids. So I'm not arguing that it can't happen. And the brain examples that you mentioned, that may be a special case as well. I'd have to go back and review that. So I'm really glad you brought some of those things up. But generally for infection, overwhelming infection with even Neisseria meningitidis, there isn't great evidence that using corticosteroids actually improves survival, to the best of my knowledge. The secondary question about CD4 cell, positive cells, and what happens late during infection, those are, I don't have the answer. I'm not an immunologist, I'm a clinician. But that's an interesting question about the CD4 positive cells, T cells, in COVID-19. And I think that the point you make with the late worsening of patients, the fact that they can seem to have like almost a false improvement, and then patients seem to kind of go down the toilet and get really, really sick with what appears to be and has been described as a cytokine storm. That's why there's so much interest in these treatments. And it really begs the question about whether the immune system is going completely nuts in these situations. I think that history and some of the reasons I brought up should give us caution, but we'll have the answer to that, I think, in relatively short order about whether that's a strategy worth looking at. But thank you.
Thank you.
Great. Well, we've got a lot of interesting questions in the chat. I'm going to go to one from Summer from a little while back. Summer asks, if you're adapted for high levels of inflammation, would you be better suited to endure a cytokine storm?
Oh, that's an interesting question. I'm trying to think of a situation in which we'd be adapted for a high level of inflammation. And I suppose if we're born into an environment that has a high infectious burden, And people have argued, say, with the predictive adaptive response, that babies that are born small, for instance, have more immune reactivity that may lead them to kind of late inflammatory consequences like cardiovascular disease. But it's thought by some that that thrifty phenotype may actually cause more of an inflammatory milieu in the body. So I suppose that's possible. Quite frankly, I haven't spent a lot of time thinking about it, but I appreciate you bringing that point up.
Great. Looks like we have a raised hand, so I'll go to Peter Woods. Peter, you're unmuted. Go ahead.
Hi, so it's Peter Woods from the UK. So there's this like growing body of evidence that we can prognosticate people with sepsis and ARDS and similar inflammatory conditions early on in the illness, and that we can make this group of like people who are overreacting because their biomarkers are so high, and they're the ones who go on to have worse outcomes. So when you do like a post hoc analysis of the studies, such as like Corticus is the one I've seen done, but other immunomodulatory studies, this seems to have positive impact within this very sick overreacting group, as it were. And also in my experience of COVID, there seems to be two different like phenotypes, where one is quite happy with this like hypoxia, shows some clinical signs, but others seem this like over the top inflammatory soup, cytokine type thing. I suppose my question is that very sick subgroup those who are overshooting, and should we specifically be looking at them for immunomodulation as opposed to the whole group where we might end up masking any benefits?
Well, thank you, Peter. Those are excellent questions, and it's good to see you. I would say that sort of of course, some people are asymptomatic or have minimally symptomatic, and we're not thinking of treating those patients with any sort of immunomodulatory or any treatment at all, really, because it can be self-limited in that population. If we go back to the sepsis idea, of course, the thing that people first reached to when these first trials didn't work was they said, well, we must be looking at the wrong patient subset. And in fact, some people still argue that. And they've done very, very large trials. And then if you do a subset analysis, sometimes in post hoc fashion, like you mentioned, we do find that some of these medicines seem to work maybe in the sickest patients or certain kinds of patients, but then you have to go back and test that group prospectively. This is exactly what happened with Xigris, which is the medication that was approved by the FDA to treat sepsis. It had both blood thinning properties and anti-inflammatory properties. And it had the first trial seemed to work, but then when they looked at it in all comers, it didn't work in people who were less sick. It didn't work in post-surgical patients. It didn't work in pediatric patients. And so the European version of the European Medicine Association required a very large scale trial in the very sickest patients. So the ones that you'd expect would benefit. And when they did that trial, it didn't work. And that has been a similar story for other sorts of treatments for sepsis. So even though that's an attractive idea, it hasn't worked out very well. And of course, we don't really know in COVID yet.
Great, thanks for that. We've got another raised hand from Sequoia Snow. Sequoia, you're unmuted.
Hi, thank you so much. So there's been papers that reference antibody-dependent enhancement, and it's also been shown that in the initial area where the outbreak occurred, that there's been greater severity because they're thinking that the pre-exposure has developed the antibodies to another, I guess, version of SARS-CoV. And so I'm wondering about the ADE effect. And there's also been articles that reference a cross-protection with people who have gotten the MMR vaccine because it shares like a similar protein domain. So what are your thoughts about the intersection between actually developing a vaccine towards COVID to develop that antibody and the cross protection from previous vaccines and the priming of our immune system that causes a more severe, I guess, reaction to COVID may be due to the antibody-dependent enhancement. What are your thoughts about that?
Again, terrific questions. I don't have any domain of expertise in vaccine development, but I think that that idea that maybe people in Wuhan, China had been exposed to previous coronaviruses and may possibly have a more vigorous immune and dangerous immune response as a result, which is the opposite of what we'd expect from vaccination generally, that could be a problem. And I do understand that a similar problem has plagued the development of a vaccine for Ebola virus, that sometimes you can give a vaccination against some antigen or epitope of the virus and it causes an immune enhancement. That certainly happens with dengue fever. That's another virus that we don't have a vaccine for yet for that same reason. So really super interesting questions. With regard to MMR, I haven't heard that. I have heard that I think it's the BCG vaccine against tuberculosis has been thought to provide some protection, but the jury's out on that one.
I think poliovirus too. There's some talk about that as well.
Okay, so I haven't.
That's really interesting, and yeah, that's great. Great question. And I just want to add that if somebody out there knows anything about some of these topics, please feel free to raise your hand or to contribute to the chat box if you'd like to weigh in on some of these different answers and questions.
Please
Thanks.
do.
I'll turn things over to Meredith who is keeping track of things in the box.
James Gurney had a response to the CD4 question. Maybe he wants to jump in. James?
I'm happy to unmute myself if everyone can hear me. Yeah, sure. Just that we know that the CD4 and CD8 response is typical of recovery for COVID-19 patients. That's how obviously the immune system becomes able to deal with the virus. Again, not really my specialty. I just because I was researching that one of the public health video things, so I had to look into all this stuff.
That's great. Well, thanks for jumping in.
All right, so it looks like we have another raised hand, so we'll go there before jumping back to the chat. This is a raised hand from Jay Brinkworth. Jay, you're unmuted. Go ahead.
Awesome, thanks. Yeah, so what I was going to say was there's a limited amount of experimental data around 1918 flu that shows, at least in a pig model, that a really strong cytotoxic lymphocyte response can be primed via other influenzas. So that's another, I guess, possibility like that falls in the same realm of like antibody priming. The other thing I was going to say around vaccine development, one of the big problems that's also being faced is that coronavirus responses to coronaviruses, like notoriously antibody responses, fade out. So we lose titers at like year 2, year 3. That's the case with SARS. That's the case with MERS. That's the case with other experimental models, including murine hepatitis virus, which is really closely related. So that's another like grander challenge around development that's potentially an issue, which is technically taking things off topic, but I was bursting with excitement to say it, so I popped in.
Yeah, thanks for that. I don't have too much to add to that. It is interesting and a little dismaying to learn about these declining antibody responses. So even people that perhaps have had infection may be vulnerable to a infection later on after a year or two. That's kind of scary.
Yeah, they're done at 3 years. There's all this retroactive work on SARS and these papers that are published in like 2005, 2006, where they're just gone. Like it's really, really disheartening.
Thanks for chiming in on that. So jumping back to the chat box, there's a question from a while back that I'm super interested in. This is from Michelle Blythe. Michelle asks, as an infectious disease fellow, I've noticed that most severe COVID patients are not young and healthy and often have comorbidities that are considered immunosuppressive. I would expect that if the patients that would overshoot would have very functional immune systems, but this isn't what we're seeing. What are your thoughts on that?
So I'd actually like you to chime in on what your thoughts are, Michelle. But I guess my personal thought on this is that I saw an early report that was a patient who was immunosuppressed who'd gotten an organ transplant where they said, yeah, he was viremic and was shedding lots of virus, but wasn't showing any symptoms. So that would go along with this idea that the immune system is overreactive and that being suppressed might be helpful. But then there's lots of counterexamples of that too. Of course, aged people that are relatively immunosuppressed have problems. There have been other reports about patients on immunosuppressive drugs that have done very, very poorly. So I think in general, it's better to have a competent and vigorous immune response, especially early in the infection, which may be one of the reasons why we see kids doing so well. But maybe you want to talk about obesity and other comorbidities, Michelle, if you can chime in.
Sure, I guess I can chime in on that. Hi, I'm Michelle Blythe. I'm an infectious disease doctor at Tulane in New Orleans. So we saw a lot of this. Not seeing so much of it anymore. Yeah, what we're really seeing is patients with diabetes, obesity, and hypertension being most at risk for severe outcomes. Of course, diabetes, I think everyone kind of knows, has a immunomodulatory effect that tends not to be that great. They're more susceptible to a lot of other diseases like Pseudomonas and so forth. The obesity thing, there is actually some research that indicates that obesity in and of itself can be an immunomodulatory condition leading to suppressed immune responses. Though I'm afraid that maybe in COVID, it's mostly a function of physics when trying to ventilate a patient more than anything else. But yeah, I think it's interesting because I feel like the patients that are doing so well are the young and healthy ones with really good immune responses. And you know, most of our mortalities have been seen in patients with a lot of comorbidities, significantly older patients, patients from nursing homes, that sort of thing. So I guess there might be a possibility that it's that because of a suppressed or quite not functional immune system, that the immune system is going off in a wrong direction. But that's the only thing that I can kind of think of that might be supporting the immune hypothesis.
Yeah, that's a very interesting thought. I think that it's pretty clear that patients with diabetes and those who have severe obesity, their immune systems are different than people that don't have those conditions, and tend to have more low-grade inflammation and may not respond as vigorously to certain other challenges. And that could be what we're seeing with COVID. But yeah, thank you.
All right, looks like we have another raised hand from Ed LeGrand. Ed, you're unmuted, go ahead.
Okay, I'd like to address the question of why it is that immunosuppressed people tend to have worse responses and then they overshoot. As I see it, if you have a normal, healthy immune response, you can stop the infection early. You've got everything working properly, and you just don't get past that bad stage. If you have a defect in your immune system, now it gets to a dangerous, a severe level, and now the body has to react with all it's got, and it may be defective in one set of immunity, and it has to compensate with even more of the less effective types of immune responses. So as I see it, a healthy immune system early on stops it from getting out of control, and then once it's out of control, then the body has no choice but to use all it's got. And as far as there are situations, I know certainly with flu and presumably with COVID, that the immune response is overkill. And if you let the virus have its way, then you'd recover. But I would suggest that those are exceptions, evolutionary exceptions to infection. And you generally want to stop an infection early. It's a positive feedback system with a exponential growth curve. You've got to hit it early to stop it, even though it seems excessive early on. If you don't hit it early, then it gets out of control, and now you have to hit it with such force and a defective force because you don't have all your immune system working properly, and that's when you get in trouble. So that's my take on it.
Thank you, Ed. And I think that bringing in sort of the temporal aspect of this is something we have talked about. There's a timing issue. Yeah, having a robust early response can really prevent a lot of downstream later exacerbations. So I agree with your point on that. That's an interesting way to frame it.
James, did you have something you wanted to add to that or a different question? You can go ahead, you're unmuted.
So yeah, just to follow up, really, that it's worth considering that all these, when we talk about cytokine storms, they are not a single thing. There are many different ways the immune system being modulated by these viruses. Like the way measles modulates the immune system is very different from how COVID does. How Ebola modulates, it still produces a cytokine storm, but it typically has like DIC and the list of cytokines that is actually modulated are different. So I would say, just because in the 1980 flu, where we had what looks like a cytokine storm actually doing a lot of the killing for 20 to 30-year-olds, just because we call them both cytokine storms doesn't mean they're actually the same thing. There were different ways the immune systems could be modulated. And with the COVID-19, it seems a lot of the early mismodulation is neutrophil recruitment, things like that. So things that wouldn't necessarily help the virus, even if you had a quick upfront response from that part of the immune system, it would do very little to actually help treat the virus. It just excretes elastase all over the lungs and degrades them and kills cells. So it's, the takeaway is not all cytokine storms are the same thing.
Great points. A couple of reactions to that is that one, I think it's when we think about how effective immune responses, and we think about, say, antibody responses to COVID, which can eliminate and clear the infection, there's been a lot of attention about the importance of the adaptive immune response when it comes to viral infections. I think what we're learning both with influenza and certainly with COVID is that having an appropriate innate immune response, things like the elastase production by neutrophils, is maybe more important than we thought. And it certainly isn't as clear-cut that it's always harmful as the people arguing for cytokine storms seem to suggest. Yeah, great points.
Great, so we've got time for probably one or two more questions. Looks like Jay, did you have a question?
I was just gonna, because we do a lot of neutrophil work in my lab, point out that, so neutrophils are supportive in viral infection, but they run through the lungs as part of their natural life cycle. The marginated pool ends up in the liver and the lungs often. And so if you were having a really severe infection, whether it be viral or bacterial, you would still expect to see increased trafficking. I mean, really severe, increased trafficking running through the lungs. And yeah, they do, when they get there, they are activated, right? They've been pulled out of the marginated pool to be activated, and they run back through these marginated areas after the fact. And that's when they're spinning this elastase around. So it's bystander tissue damage, but it's not necessarily the model that we've all been brought up with, which is that neutrophils are rushing to the site of the infection. This is a location that they're going to anyway as part of dying off. So I think there's a lot that we don't know about that cell type in particular. And I think there's a lot that we don't know about in and around just like viral responses that extend outside of monocytes and T cells that makes stuff like this really difficult to model in an actual patient.
Yeah, thank you, Jessica, for those comments. You're certainly way more expert in neutrophils than I am. But if you go back to the 90s, there was a lot of emphasis on anti-neutrophil therapies for lots of different things, and even using things like ibuprofen to decrease neutrophil activation. And those kinds of interventions, by and large, have not worked for infection generally. But yeah, the fact that the lung serves that function, that the neutrophils have to pass through it. I also think the lung can serve as a bit of a pathogen trap, which is something that we've talked about, which is an interesting idea.
Yeah. All right, so maybe one more question. Looks like we have a hand raised from Randy Nessie, so we'll go there. Randy, you are unmuted. Go ahead when you're ready.
Hi there, thanks. So Joe, wonderful. I'm so glad to hear this review. I've been looking for something like this. But some of us have a special interest in why old people are dying so much. And one possibility is just that old people have less robustness in general. Another is there's something special going on. Do we have any data about death rates for healthy old people that might help us towards this?
So you're looking for some reason for optimism?
Yes, I am.
Certainly, I think what we're learning is that being a healthy old person is way better than being a person with old age plus a variety of other comorbidities. And there's some good examples of people who are in the older categories who have obviously survived this or have had minimal symptoms, many people in their 70s and above. But it's pretty clear cut that as far as risk factors for worse outcomes, being male isn't a good thing. It seems to, I think the increased odds is 1.8 increased relative risk compared to being female. And with age cohorts, it certainly goes up dramatically as you approach 80 years old and above. So it gets pretty scary at those ranges. And I think that immunosenescence is part of the answer here, at least with regard to the age question. One thing that hasn't really been looked at, but I'm interested in is, as you get older, you are exposed to more chronic infections. And to the extent that a whole variety of pathogens tend to have as part of their virulence program or their persistence program, circumventing immune responses, it's possible that we've acquired a variety of infections like zoster, various herpes viruses that may make us less immunocompetent when we're confronted with an acute viral illness like influenza or COVID. And I will point out that also old people have a tougher time with influenza.
Thank you.
Okay, since we're almost out of time, I think we should wrap things up. I want to thank you, Joe, for a really great presentation and leading us on this discussion. And I want to thank everyone else for this great set of questions. This has been one of the most dynamic of the Club EvMeds that we've had in terms of the questions and comments in the chat box, and that's really great to see. So thank you all for joining us, and we do have one more coming up on Monday. Would you like to say anything about that, Meredith?
Sure. On Monday, we have another Club EvMed scheduled at 12 p.m. Eastern Time, and that's going to be led by Daniel Blumstein of UCLA and Terrence Taylor of the International Council for the Life Sciences. And they're going to be talking about evolution's success in evading catastrophic risks. So that should be a fascinating conversation. So sign up for that if you're interested.
Okay, well, thank you all for joining. Thank you, Joe, for presenting, and thank you very much, Meredith, for coordinating all of this. This is great.
Yep, thank you, Joe, and thanks everyone for attending. I will send out a recording soon.
Thanks, everyone.